Good morning, everyone. We're going to proceed with the session soon. And please, everyone, have a seat. And we would like to make announcement about the new format of this meeting regarding the presentations, as well as the discussions, as well as the answering the questions. Dr. Bernard is going to make announcements regarding the tweeting. Something that we do this year, and it's the first time they're going to try, to encourage participation from the audience regarding commenting on the presentations. So everyone can tweet, and Dr. Bernard will tell us a little bit about it.
Okay, this slide is going to be up more than once, so you'll get a chance to do this. But what we really want to do is encourage you to ask questions through this, and this is going to be our technique. And what you have to do is you have to download Twitter, and then, or if you have Twitter, you have to find us on it. Just for right now, don't rotate through the slides. There we go. So once you do that, go down to the bottom where you find the little search glass and click on Explore. And what you want to do is bring up AAPS 1921, and that is the Twitter account for the association. And then anytime within your own Twitter account, the one that you set up, you want to put the @ with AAPS 1921, and then put your question in. And then the moderators who are up there, not the moderators, both Dr. Johanna and myself, we'll get these, and then we will pass these questions on to the various participants in the scientific program. And then just to go over the rules again for the folks that are here, and this is also going to be rotating through in between each of the sessions, so everyone's aware of the rules. There's a total of 15 minutes for each paper. Within that 15 minutes, there's going to be 8 minutes for the paper. A red light will flash at the end of that time. You're expected to rapidly bring your talk to an end if it hasn't completed by then. The discussant will then have a total of 2 minutes, and then Dr. Johanna and myself will just gently cut the discussant off so that there is time for answering that question and time for questions from the audience on each paper. And with that, I'm going to pass it off to our moderators for the first session, and we'll go ahead and get started. Paper number 1 has been withdrawn, and so we are going to start with paper number 2.
Our first paper will be Salvage Ear Reconstruction of the Unsatisfied Patient by Dr. John Reinisch.
Good morning, members and guests. We have no disclosures. There is a dichotomy with ear reconstruction. Patients feel that the reconstruction of the external ear is a cosmetic procedure, and they expect it to look like the normal opposite ear or a normal ear, while the surgeon thinks of it as a difficult reconstructive procedure and doesn't use the same metrics to judge the outcomes as they would with other cosmetic procedures. Patients, I think, and surgeons both agree that in the end, they are generally a little disappointed with the outcomes. We looked at patients with unsatisfactory outcomes that we operated on in a 15-year period, and these were not revisions, these were complete redos. We had 117 patients, mostly male, and at the age of surgery, there was a 50-year span. 9 patients had amputation and prosthesis as their initial procedure. 27 had MedPOR as their initial procedure. 4 of those 27 were our own patients, and 81 had costal cartilage, as you would expect, for a total of 117 patients. The method of salvage, we used MedPOR reconstruction for all of these patients. We used temporoparietal fascial flap as our initial procedure, if available, and if not, we used the occipital parietal fascial flap We used free flaps when neither were available in 4 patients, and we were able to salvage all but 1 patient. So I'll give examples. This is a patient who had a prosthesis for the last 35 years. He's a little swollen in this picture because he had rib cartilage reconstruction of his hemifacial microstomia and had ankylosis of his jaw, and we put in a TM joint, a prosthetic TM joint, but it shows his prosthesis. This is what it looked like before actually that surgery. And interestingly, he had a tissue expander placed in his scalp, and the hair in front of the ear was a flap from the side of the head to cover the junction of the prosthesis with his cheek. And therefore, he didn't have a TPF flap or an occipital artery to use. So we did a radial forearm fascial-only flap on him, and this is a almost 10-year follow-up. That little pigment was my attempt to do a tattoo to make it look like he had a canal. I didn't get it in the right place. This is a patient who had an amputation when he was a child, hated his prosthesis, and we did a med-pore reconstruction. This is a 12-year follow-up. A girl from China, you can see the who had a failed ear reconstruction and then had, you can see where the pins were to hold her prosthesis, which she didn't like. And we did this is just 2 weeks, I think, after her surgery, and good symmetry. These are examples of prior med-pore reconstruction. This is a patient from Korea that had an exposure. The surgeon nibbled away at the implant, which was not successful. We removed the implant, let it heal for 4 to 6 months, I don't remember exactly, and then used the occipital artery fascial flap, which you can see here. This is what it looks like. This is not that patient, but it's another patient. And here she is 2 weeks after the surgery when we removed the dressing. Here she is a year and a half later. A similar patient done by the same surgeon, and you can see in this he got an exposure and used a scalp flap to cover the exposure, which was not successful. And after an occipital flap, good projection and good contour. This is a patient from Kansas City who had a med-pore just put under the skin, which is rarely successful. The patient had a prior ear canal, which stenosed. He had a number of little exposures, and we just removed that, did a TPF flap, and covered it. This is before he went home. The stitches are still in place, but you can see good projection. This girl is from Mexico with bilateral microtia and had bilateral tissue expanders placed. The expander here became exposed and was removed. This expander was removed and a med-pore was placed under the ear, and you can see there's an area of exposure which you'd expect under placing med-pore under skin. Does not work. We were able to use a TPF flap to reconstruct this ear, and this side, her superficial temporal artery was not available when we did an occipital flap. But you can see good projection and good symmetry. The majority of our patients are costal cartilage patients. This boy from St. Louis had 4 surgeries with cartilage, no projection, a scarred earlobe, and you can see 1 surgery outpatient, good projection. The earlobe is not ideal because of the scarring, but good projection. This girl had 4 rib cartilage surgeries and an ear canal, and this is after 1 outpatient med-pore surgery. Good projection. Boy from Cincinnati, again, 4 surgeries, scarred earlobe, as you can see here, better projection. Girl from California, 4 surgeries plus an ear canal. Here she is after 1 surgery. These are all done as outpatients, which is fitting with our Cascadon lecture in terms of the healthcare costs. This man at age 7 had 7 surgeries beginning at age 7. Here he is almost 50 years later, never happy with his ear, and decided finally to do something about it, and after 1 outpatient surgery with med-pore and a TPF flap. This boy is from Tampa, Florida, had 4 cartilage surgeries, no projection, and in 1 surgery we removed the cartilage, did an ear canal, and did a med-pore surgery, and this is him a year and a half later. This is a patient from our own institution otolaryngologist did a cartilage reconstruction. The skin died, and he, for some reason, transferred a scalp flap and did a skin graft. This is her at 27. We did the surgery when she was 10, so this is a 17-year follow-up. This is a boy from India who had rib cartilage. He has hemifacial microsomia, so the rib cartilage was placed anterior to the hairline. You can see where the ear really belongs, which is really under the scalp. And here he is after that surgery. And at the same time, we put fat in his cheek, which we do frequently, and also corrected his macrostomia to give him better symmetry. A boy from Bolivia, this is before he went home. The skin grafts have funny color, but they did fine. Good projection of his ear, as you can see here. And this is a 4-year follow-up showing that the ear survived, and he's happy. This is a man from Vietnam who had surgery in Orange County when he was a teenager, never happy with the ear, and we replaced it with Medpor and a TPF flap. Okay. And just finishing up, so in summary, patients are often disappointed with the rib cartilage reconstruction, but reluctant to do anything more because of their bad initial experience. I think Medpor is a cost-effective and good alternative because of the lack of pain and the fact that it can be done as a single outpatient surgery. We find that the results that we have obtained are not as good as our primary reconstructions because of the scarring. So this is a primary reconstruction, no scarring beforehand. This is a girl I saw yesterday in the lobby who we did 3 years before, who lived here, just showing good results, better than I think our secondary reconstructions. Despite that, we have a high rate of patient satisfaction. Thank you.
Now I have Robert Walton will be the discussant, 2 minutes.
Thank you for allowing me to discuss this paper. Clearly, in the hands of the senior author, an acceptable, durable ear reconstruction can be achieved with the porous alloplast scaffold. There's a growing body of evidence to suggest that the duplication of the exact shape and size of the ear is not as important as its position on the head, its projection and size. So it really doesn't make any difference, and that's why the porous polyethylene sort of intuitively works, because it doesn't duplicate the exact shape or configuration of the opposite ear. It confounds me to understand why the secondary reconstructions weren't as good as the primary reconstructions, because you're using fresh fascia and fresh skin grafts and an alloplast scaffold, and how would that impact on the position and the projection of that construct? I enjoyed the paper, wish that I'd had a more complete manuscript to review prior to this review.
Thank you, Bob. I think we do get good projection. We try to use, when I say it's not as good, there's scarring of the earlobe from the initial surgery, and there's not as much available similar colored skin. So we try to use the skin that's there covering the previous reconstruction, but it's not enough, especially to give a conchal bowl. So then we end up taking additional skin. The skin is often taken from behind the other ear, so then the color match may not be as good. And those are the reasons that, and sometimes when the position is too anterior and we move it back, then you have scarring on the cheek. So those are the reasons why the secondary reconstructions aren't as good as the primary. But I agree with you that what makes a good ear is a deep conchal bowl, good projection, a nice helical rim, and if it doesn't exactly match, it's not like an eyelid. You don't look at one ear and then walk around and look at the other ear and realize that the crus are not exactly the same distance apart. But if you can get an ear that's the right position on the head and sticks out and has good depth to the conchal bowl and a good helical rim, that makes a good looking ear, and you don't look at it and it doesn't attract attention to it. And I used to do rib cartilage, and I never was satisfied with my end result. That was the reason we developed this technique. Questions, please.
Jesse?
Hey, Jesse Taylor from Philadelphia, Pennsylvania. John, as someone who's admired your work from afar over the years, this is another incredible presentation of incredible results. What do you find as far as migration of these secondary cases over time? Do they similarly migrate inferiorly and maybe rotate a little bit like the primary cases, or have you found something a little bit different?
Yeah, that's a good question. So what Jesse's referring to is we're very good at following up patients. I saw 3 patients yesterday when I checked in, because it's very important to follow up and see how you're, like breast reconstruction, you want to see if they, or reduction, you want to see how they bottom out, because it influences the way you do the initial surgery. Or cleft lips, if they pull up too high, you want to adjust that in your initial surgery. And I think people's results vary depending on their own individual, it's not the technique, it's the way they do it. So we have noticed, well, 2 things. We noticed in our follow-ups that ears don't maintain their projection as well as we had hoped. And so about, I don't remember now, 5 or 6 or 8 years ago, we started to use a silicone mold at night to maintain the projection for 4 months following the surgery. So the parents make it, it lasts for probably a month or 2 months. It's like Play-Doh. They put it over the ear at night, but it may pull the ear back a little bit so that the tilt of the ear can be increased. And also the ear we've noticed, tended to drop. So the 2 things we do now to prevent that is we use a little deep temporal fascial leash to sort of hold the implant a little anterior, maybe a ½ centimeter more than I would, and a little bit higher than I would. And that seems to help. And we do it for the secondary reconstructions as well as the primary.
And I think just to follow up, another important technical point is the positioning of the ear in the hemifacial microsomia patient, in which you really don't have great landmarks. How do you rotate that lobule further north in order to get the ear in the place that it needs to be relative to the contralateral ear?
So many of those kids, well, I measure from the lateral orbital rim to the anterior most portion of the ear, and I transpose that to the other side. That often makes in a hemifacial patient that the ear position is in the hairline, or to a large extent. The earlobe is often okay, but if it's not, you may have to come back and do a minor thing to advance it up. But I try to inset it, and then the pedicle can then be advanced a little bit more secondarily in the ones that are significantly dysmorphic.
Have you looked at the causes of patient dissatisfaction with the result? Have you tried to categorize those? Does the severity of the original deformity impact on the ultimate outcome of the ear reconstruction?
I think that's so multifactorial. I think it's hard to know. I mean, I think the patients just want to look in the mirror and see an ear that looks and sticks out well. They can wear glasses on it. We're part of something new called the ear Q study that is like the Cleft Q study, and it's just impressive how patients don't look at dissect the little parts of the ear to see what they don't like. It's just that they know they don't like it, but it doesn't stick out, or if it's too low or too scarred. And basically, most people don't look that carefully at people unless there's something that calls their attention. So as plastic surgeons, we just want to get under the threshold of noticeability. And if you can do that, then, of course, when you point out that I've had ear reconstruction, people notice it. But when they're talking to you, they don't. And I've often thought, everybody thinks we're great surgeons, but we don't have some measure like in golf, like a handicap, where you can say, how close do you have to be to notice a deformity? And maybe we should have scores, where a panel will look, and then you could say, my score is 4 feet, what's yours? But I think that's what we want. We want to be able to make an ear that doesn't attract attention until you point it out, and maybe, of course, then they would realize. But that's what we're hoping to get. And interestingly, it doesn't have to be an exact copy of an ear. I redesigned the implant to make it look more anatomic, and I don't like it as much. So it's actually better to have the two crus, the scapha being, or the fossa triangularis to be wider, because you get better definition and it looks better.
Okay, thank you very much. We're going to have to move on to the next speaker. Thank you for that excellent presentation.
Our next paper is Predicting Risk for Adverse Perioperative Events in Patients Undergoing Furlough Cleft Palate Repair. Presenter will be Dr. Martin Basta.
And once again, please have the presenters come up to the front of the room so we can minimize the transition time between the talks.
Good morning. Thank you for the opportunity to present. We have no disclosures. Cleft palate occurs in approximately 1 in 1,000 live births worldwide. In the U.S., there are about 5,000 cases that are performed on an annual basis. The timing of repair typically is between 10 and 12 months of age. Traditionally, outcomes have focused on longer-term surgical outcomes, such as oronasal fistula and VPI, bilopharyngeal insufficiency. What about adverse perioperative events that occur in the shorter term, such as airway obstruction, broncholaryngosspasm, or need for reintubation or hypoxia? Well, we feel that these are maybe an underappreciated complication. In literature, there's a reported incidence between 4 and approximately 40%. A cursory literature review identified over 11,000 articles that report on cleft palate surgery. However, only 36 of these look at perioperative anesthetic complications. And they're clinically relevant as they lead to additional postoperative complications, prolonged hospital stay, and contribute to parental distress. What are risk factors for APEs? Well, pediatric patients have inherent risk factors such as a smaller airway and one that is more reactive with a greater postoperative edema response. There are also procedure-specific risk factors. Patients have abnormal airway anatomy, such as this patient with Perioperative and micrognathia. Patients with syndromes have multisystemic manifestations of illness, such as hypotonia, which can contribute to risk. And the majority of these patients are typically younger in age and have a lower weight at the time of surgery. The objectives of this study were first to determine patient and perioperative factors that are independently associated with the risk for APEs, in order to create a risk assessment tool that can quantify individual APE risk. Regarding design, this is an analysis of a previously published retrospective cohort in Cleft Palate Craniofacial Journal in 2012, where we looked at all patients that were 2 years or younger at the time of primary repair, done via the CHOP-modified furlough palatoplasty at a single institution. We built upon this prior study by creating this risk assessment tool. Patient factors we looked at included age, weight, and gender at the time of surgery, voc cleft palate type, and syndromic diagnoses. We looked at known airway problems such as history of prior APE, structural airway disorders, reactive disorders, and recent URIs. Surgical factors included operative time, any presence of modifications, and combined procedures. And anesthetic factors included the number of intubation attempts, total narcotic dose administered, the use of a paralytic agent, and whether or not it was reversed, as well as the presence of difficult intubation preoperatively. Finally, provider experience was reviewed and defined as the number of years in practice, and unique to anesthesia, we looked at the number of provider handoffs. The primary outcome was adverse perioperative events, which included laryngospasm, bronchospasm, desaturation to below 85% for 45 seconds or longer, airway obstruction, accidental extubation or need for reintubation, and unplanned ICU admission. We performed basic summary statistics of each factor. We then, to create the model, took factors that were significant in univariate tests of association, entered them into a stepwise multivariate logistic regression. Those factors that remained in the regression in the end were used to create the risk stratification tool, in which each factor was assigned a weighted risk score, and then each individual a composite risk score based on their individual risk profile. Looking at the results, 300 patients were included, with an average age of 12 months and weight of 9.1 kilograms. There was an equal distribution across gender, Syndrome was diagnosed in 23% of patients, the majority of which were Pierre-Robin or Stickler. Abnormal upper airway anatomy occurred in almost 20% of patients. Average operative time was just over 2 hours. Narcotic dose averaged 0.2 milligrams per kilogram. And regarding experience, surgeon experience was 14 on average, and anesthesiologist 13 years on average. This figure looks at the VO cleft type composition, the majority of which were either VO class 2 or VO class 3 clefts. Adverse perioperative events overall occurred in 69 cases with an incidence of 23%, the most common of which included airway obstruction and desaturation. Reintubation occurred in about 5% of cases. Regarding patient factors associated with APEs, the most significant of which were abnormal upper airway anatomy and OSA. Other significant factors included having VO class 2 cleft or a syndromic diagnosis. Age notably was not a notable risk factor, whereas having a weight between 9 and 13 kilograms at the time of repair was found to be protective with an odds ratio of 0.6. Regarding perioperative factors, the most significant was 2 or more intubation attempts. Other factors that were significantly associated with APEs included inexperienced provider, a history of prior APE, prolonged operative time, and a greater narcotic dose. We found that patients who received paralysis and then were reversed were less likely to have an APE with odds ratio of 0.4. This is the final regression model with corresponding risk scores on the far right column. The most significant of which were having 2 or more intubation attempts or a structural or functional airway anomaly with risk scores of 3 and 2 respectively. In the bottom, weight was found to be protective and the risk score of a -1. The patients were then given a composite score based on their presence or absence of these factors and grouped into 4 different risk stratification groups. Low-risk patients had a risk of 2.5% APE, moderate risk 13%, high risk 40%, and extreme risk over 92%. The model was assessed in terms of performance by doing ROC, receiver operator curves, and this graph just compares the composite risk score model to the original factor model from which it was derived, and both show a C-statistic of approximately 0.8. In terms of clinical application, well, this tool shows that with increasing composite risk score, there's an increase for APE risk that's predictable. Its strengths include that it's informative with a nearly 40-fold discrimination in risk. It's accurate, C-statistic of nearly 0.8, and it's readily applied in the clinical setting. Regarding future directions, primarily this model can be used to identify patients who are higher risk for perioperative events. Knowing that, we can then try to better assess the efficacy of various airway protective measures, such as a tongue stitch or NP airway. We can define and establish criteria for escalating or de-escalating level of care, and further investigate the use of perioperative steroids and whether or not that has any role in risk reduction. However, it is limited by its retrospective nature, and there is currently a multi-center observational cohort designed to prospectively validate this risk model. In conclusion, adverse perioperative events are common. Risk is influenced by patient, provider, and operative factors, and risk models such as this one provided here may identify potential targets for risk reduction in the future. Thank you.
Thank you. We'd now like to invite Dr. Stephen Sullivan to discuss the paper.
Martin, congratulations on the beautiful paper. We heard last night from Dr. Litton Whitaker, who I think would be very proud of this paper as it truly represents the spirit of academic medicine. When you, as a medical student and now resident, approached Dr. Oksana Jackson and worked very carefully to analyze a large set of data and come up with the results that you've demonstrated today. The results of this project, I think, will truly change how we care for children with cleft lip and cleft palate. I found it particularly interesting that you focus not just on patient-specific variables, which most of us tend to do, but instead you also included provider-specific and medical practice variables, many of which turned out to be the most significant in this model. With a large set of carefully collected data, it's very tempting to throw all of these variables into a multi-regression model. The problem with that is that at the end you see what falls out, and whatever is significant then you declare that to be important. I think statisticians, however, might pause with this and wonder if perhaps this leads to increased risk for type 1 statistical errors, meaning that we declare something to be important when in fact it's not. In this paper, did you carefully select your variables a priori before you ran the model? Also, I wonder if some of your variables were actually duplicated or triplicated. For example, in your model, you included 2 patient factors, one of which was abnormal upper airway, structural, and functional, as well as obstructive sleep apnea. You also included the provider factor, difficult intubation. Don't you think that all 3 of these actually might be measuring the exact same thing, and therefore only one should be included in the multivariable model? Also, how were some of the variables chosen? For example, how was your definition of hypoxic event determined? Patient weight categories and doses of opioids. As we know, not all opioids are created equally. A milligram of morphine is not a milligram of Dilaudid, and therefore should these be converted not to milligrams per kilogram of patient, but to opioid equivalents. And then lastly, a 23% incidence of adverse perioperative events is so high. With this information, do you feel that the results of your paper end the controversy and tell us that palatoplasty should be repaired with an inpatient stay for all patients? Again, congratulations and wonderful paper.
Thank you. I will try to answer all those questions, Dr. Sullivan, as best as I can remember. Beginning with the last one, I don't think this study will in any way end any controversy because there's still other studies that are coming out based on NSQIP data, based on international cohorts that do have very discrepant outcomes. And again, the range is so wide from 4 to 40%. So we can just take what we have here as what it is and go from there. In terms of factor selection, we had multiple meetings and they're across multiple disciplinary meetings with the anesthesiologists as well, and we tried to come up with what factors were already in the literature and start there and go from there. And regarding adverse perioperative events, their definitions, there is a good amount of anesthesia data regarding what is defined as a perioperative event, what the specific criteria are for each perioperative event, and it's mostly established in general pediatric cohorts. So we just used their definitions for what an APE was. And then probably the most significant question is whether or not some of the factors overlap and that sort of thing. And the model that I presented here is slightly different from that was put in the initial abstract here. Difficult intubation, for example, was taken out in terms of definition of APE. The reason for that being I did feel like it did duplicate the data and there was such a high concurrent risk of difficult intubation and subsequent perioperative adverse events. Other factors, I tried to create composite variables that kind of group them all together and see how there were different interactions. So I included kind of structural and functional airway anomalies together because those patients seem to behave the same way. Whereas patients with reactive disorders, we grouped separately. At the same time, we looked at patients who had VO class 2 cleft, for instance, and they had worse outcomes. At the same time, syndromic patients had worse outcomes, and we know that syndromic patients tend to have VO class 1 or 2 clefts with slightly different morphologic characteristics. In the final model, the cleft type was not included, but having a syndrome was. And so that's just another example of us trying to be very careful in model design. That being said, we do have a prospective cohort going on right now, which we hope to better control for all of these various interactions and variables and see if we can replicate our data.
Question, Steve Buckman, Michigan. Very nice. There are 2 questions I have, just real quick. One is, what I realized a long time ago is I would get sometimes referrals in for people that actually had failed intubations from the outside or very difficult airways after they actually did the palate repair. So when I see anything about an airway or a very protruded mandible, I immediately go to 18 months. I kick that can down the road for all these airway reasons. Did you guys do that? Did you look at age or the ease between providers saying, you know what, this person's slightly at risk without necessarily, you can get a sleep study, but even without that, so that, you know, structurally you're seeing that there are differences there. And my second question is, because I thought the narcotic part was interesting, if I'm called to the recovery room, I can't tell you, it was a sort of a running joke at plastic surgery at Michigan. One of the first things that I'll do when they get to the bedside and they're having this problem is I'll say, and I'll use a word that anesthesiologists notoriously will be aghast at me, and that is Narcan. They hate the word. I don't know what it is in their residency, what they do. So we then bargain, not a full dose, maybe a small dose because it's an evil thing to do. But the bottom line is the kid will often wake up. They're in a very deep state right after anesthesia, and then we avoid reintubation, a lot of those things, because we can get them through. Did you see that at all, or did you use that at all?
So I didn't look at whether or not the patients who had adverse events and were then given Narcan or not, if there was an effect in that regard. I think there's a really complex interplay between the use of a paralytic agent, the use of a reversal agent, and the total narcotic dose that's administered to a patient in any given case. It's a very complex interaction, and I would have to probably defer to our anesthesiologists in terms of their specific discretion for what they're giving, when they're giving, and in which patient. That being said, it is likely that patients who end up getting more narcotic were probably less likely to have reversal, and also at the same time may have not been paralyzed because they had some other comorbid condition that was a relative contraindication. And that just reminds me, we did group patients according to the distribution of the dosing. And we did use morphine equivalents for each patient, and we did dose by weight. So a total narcotic dose over 0.32 milligrams per kilogram was over the second standard deviation, like 2 standard deviations above the average. So not that many patients, but those all reliably had complications.
Great. And then that last little part about the structural differences in a Pierre Robin patient or whatever, did you find that those people are pushing that down the road? Because that would make a big difference in these airway problems.
Yeah, I mean, another thing was we saw that there was a high risk for patients who were really young at the time of surgery, so less than 9 months, and then for some reason, it wasn't inexplicable, but patients who were older than 9 to 15 months had higher risk as well. And what happens is that patient population overlaps with those who are sick and who need more time, but they still had the complications. So,
thank you.
Sure.
All right, thank you very much. We're going to have to move on to the next speaker. Thank you for an excellent presentation.
Sure. Thank you.
So our next talk is Optimizing Reconstruction in Craniosynostosis, a 10-year review of 141 non-syndromic patients treated with a novel technique. Our presenter is Haim Rudy.
Hi, I'm actually Sean Herman. I'm presenting on behalf of our institution, Montefiore Medical Center in the Bronx. I'll be talking to you today about a retrospective 10-year review of non-syndromic patients who underwent open cranial vault remodeling using a suture trellis technique. As we know, craniosynostosis affects approximately 1 in every 2,000 live births, dependent on suture pathology, and is usually treated with either endoscopic approaches and strip craniectomy versus completely open approaches for total cranial vault remodeling. And this is dependent not only on the patient phenotype, but the affected suture pathology. The open approach is also highly variable, and methods of fixation have ranged from either no fixation to suture fixation and rigid fixation with resorbable or non-resorbable plates and screws. Along the same lines, addressing the calvarial defect itself has ranged from either using autogenous materials versus alloplastic materials, and in doing so, either bone particulate can be used, which is more malleable, versus solid grafts, which can either be full thickness or split. Traditional teaching has dictated that cranial bone isn't able to be split via this optimal diploic space that develops around 7 years of age. However, recently, Dr. Buckman's group has described a group of approximately 400 patients who underwent split bone grafting for calvarial defects successfully. Using this data and our knowledge of Virchow's law, et cetera, our team has described a technique based on 3 reproducible steps to address an anterior cranial vault remodeling. First is the frontoorbital advancement. Then this is followed by solid fixation of the bandeau, the forehead, and a sagittal strut. And the resulting lateral defects are filled with bone graft with a PDS suture trellis that is filled with split calvarium. Here you can see how the Marshak template is used in the parietotemporal region to mark out the neoforehead, which is prioritized and then secured anteriorly to the bandeau. This is secured to the 2 centimeter sagittal strut to recreate the arc, which then results in bilateral bulging laterally, and this helps normalize the biparietal diameter of the patient's skull. Subsequently, PDS suture is woven laterally to create a suture trellis, and this is interlaced with the split calvarial bone grafts. You can see here an example of a patient with unilateral coronal synostosis who underwent an anterior cranial vault remodeling procedure with frontoorbital advancement with a somewhat worm's eye view in the after picture showing a correction of that lateral bulge. And here in a frontal view also demonstrating an improved appearance and calvarium. Our group went on to describe the technique addressing the posterior vault in patients affected with sagittal or lambdoid craniosynostosis. And here you can see how the Marshak template is employed to create a neo-occiput instead with a similar sagittal arc and suture trellises laterally. In the following video, you can see the bandeau being removed. It can then be recontoured and bent, and then this piece is anchored to the neo-forehead with resorbable plates, and again can be recontoured as needed. This can be secured anteriorly in a temporary manner with some suture, just to get an idea of how long the sagittal strut would need to be. And once this is in place, the strut is secured with similar resorbable plates. And upon completion, the galea can be closed to provide additional nourishment to the bone grafts. So our single institution study looked at these patients over 10 years. And using a proprietary data mining software, we were able to accrue patients who underwent anterior and posterior vault remodeling. Exclusion criteria included those who were identified as being syndromic, and the following metrics, as you can see, were examined. We identified a total of around 250 patients, and 141 of which had complete data. There were 65 who underwent anterior vault remodeling and 76 posterior. You can see here our most common incidence of sagittal and metopic synostosis corresponding with the literature. And we were able to split calvarial bone in 100% of the patients. Here in the green, this denotes the anterior group versus the blue in the posterior. And you can see there are significant differences with the anterior group having a slightly older cohort with longer operative time and a greater blood loss, but no significant difference in blood transfusion volume or lengths of stay. When we analyzed the variables based across all individual suture types, there was no significant differences noted. Here you can see on the left a more traditional means of splitting the calvarium with an osteotome, versus on the right, you can see us using a sagittal saw to better identify that diploic space and more expeditiously split the bone itself. This can then be removed in pieces and used in the lateral defects. So we had a total average follow-up of around 46 months for these 141 patients, and we noted that only 3 patients required revision surgery, 2 of which just required a simple soft tissue revision, and 1 of which who required a repeat split calvarial bone grafting for a cranial defect. So in conclusion, our technique has led to satisfactory surgical outcomes with acceptable rates of blood loss, transfusion volumes, and operative times, which are concordant with the current literature. And patients with anterior cranial vault remodeling who underwent additional frontoorbital advancement at the time were found to be significantly older by approximately 3 months, longer operative times by approximately 60 minutes, and estimated blood loss was significantly greater at about 1.5 milligrams per kilogram. And this technique can be applied to any affected suture pathology, is easily reproducible, and can be used for both primary cranioplasty as well as revision cranioplasty. Thank you.
Thank you. We'd now like to invite Dr. Reza Chahari to discuss this paper.
Thank you. Thanks, Sean. Congratulations on the wonderful paper, and congratulations to Oren and Dave for a tremendous volume of work that you've summarized. I have a few comments. I'll be brief so we have time for questions from the floor. I'm feeling a little bit nostalgic, having just come from the American Society of Craniofacial Surgery last week and listening to Dr. Kawamoto's address there and Dr. Whitaker's comments yesterday on the history of craniofacial surgery. And I believe what we all do is somewhat derivative of these techniques that were originally designed by Tessier and his cadre of original fellows. And so I like to look at results and the new techniques that are continue to be described with that historical perspective. It seems like we started out with a number of procedures that were open and maximally invasive, and over subsequent decades we have developed techniques that are more minimally invasive, endoscopic techniques, distraction, etc. But most recently we're seeing some of the positive attributes in terms of long-term outcomes, in terms of aesthetics and neurological outcomes with total craniovault remodeling, as you described, and of course described by Dr. Persing recently. We also have at our disposal more sophisticated perioperative means of managing patients, specifically in terms of managing blood loss through hypotensive anesthesia, erythropoietin, cell saver techniques, and TXA. And regardless, I think we all have the same goals, and that's to restore relieve the restrictive forces on the brain depending upon the suture and that are involved and the dynamics, restore normal cephalic proportions in order to obtain optimal aesthetic appearance, and do this with optimum safety and long-term efficacy. But there's still, despite those shared goals, a breadth of techniques that are acceptable. So just a few questions. Number one is, why do you think you found the significant differences between your anterior remodeling and your posterior remodeling in terms of the age and the time and the blood loss? And I noted that your average age for anterior remodeling was a little bit higher than I think many of us would perform the surgeries. I think it was about 14 months. Number two is, do you think it's necessary to generate all these split cranial bone grafts to completely cover all of the dura, or is that a priority that varies with varying patient age? Are you less concerned about it in a younger patient? And finally, what do you see as the advantages of this sort of procedure as opposed to some of the more limited procedures like a posterior craniovault distraction or endoscopic approach?
So to begin with, in terms of why we observed the differences we did, I believe that the 3-month average significant difference between the anterior and posterior group could have been mainly because the patients with sagittal synostosis, it's more common. Our colleagues in pediatrics may be more familiar with this and more apt to identify these patients rather than a unilateral coronal patient who may go unnoticed for a little bit longer. In addition, this could potentially be due to additional testing that's needed for patients who are grouped into the anterior group, whether it be neurologic or ophthalmologic. And of course, there's always a scheduling issue at our institution, so that could potentially have contributed somewhat. In terms of blood loss, the anterior group did undergo additional osteotomies due to the need for frontoorbital advancement, so that could potentially explain that slight increase. And in terms of OR time, obviously adding in time for the additional osteotomies and recontouring of the bandeau most likely added to that aspect. And then in terms of identifying the need to fill in or completely fill in any bone gaps. When we split the calvarium, we usually end up with more than enough bone. So you're effectively doubling the amount that you had beforehand. And we found that this provides sufficient bony tissue to cover the dura. And small defects, usually less than 1 centimeter, are pretty well tolerated and can eventually ossify by themselves.
Dr. Hussain?
Well, thank you for describing a very nice technique, and I think that was the strength of your paper. But the question I have is the choice to compare the anterior and posterior cranial vaults, because I'm assuming if these are non-syndromic, the majority of them are single suture. So although some of them may have been multi-suture non-syndromic, but if they're different sutural problems and they're whole different presentations. So comparing what you did to a lambdoid synostosis to what you did to a coronal synostosis doesn't seem to make that much, it doesn't have that much relevance in how we approach the problem. Certainly if we looked at those patients and asked over time how many of the posteriors needed anterior cranial vault remodeling, then it would be valid to say we're comparing the results of anterior cranial vault in the two groups of patients. Just another comment on your blood loss. You said the transfusion rates weren't different. Remember, the anteriors were older, so they in all likelihood were also heavier. So the transfusion per kilogram should have been factored in. And then lastly, the question, of course, as Reza mentioned, is how will cranial vault distraction, which was not in your paradigm, alter this in the future?
Those are all very interesting questions to bring up. I think that in reviewing our group, our cohort of patients, we did identify in this study only like 9 individuals who had multiple suture craniosynostosis, which we included as they were non-syndromic. However, in going through everyone, we did have approximately 20 or so patients who were syndromic, and now we're returning and looking back at those individuals and how they compared with our 2 groups here based on which procedures they underwent.
All right, thank you very much. Thank you,
Thank you.
speaker, for an excellent presentation, and that will conclude the craniofacial section.